I'm presenting a very simple case on this winding in tubular microdiscectomy in lumbar spine. This is nothing but two-level microdiscectomy L4-5 and L5-S1 with single-level incision. To start with, a 38-year-old male policeman came with left lower limb severe pain, sudden onset and gradually increasing, with difficulty in walking since last 3 weeks. There was previous history of lifting heavy weights, and recently he develops urinary complaints. On examination, he was walking with left-sided sciatic list. SLR was positive with 60 degrees on the left side, and there was weakness in the left lower limb with the ankle plantarflexion 4/5 and the EHL 3/5. Sensations were reduced in L5 and S1 dermatome, and S1 reflex was absent, and the perineal sensations were a bit reduced. These are the MRI images. This is the sagittal cut, which is showing a large extruded disc prolapse with a extruded disc, which are caudal migration and causing left-sided significant root compression. At L4-5 level, there was a small disc at L5-S1 also, which was causing compression on the left S1 root. Dynamic X-rays were negative for the listhesis. These are the sagittal cuts. These are the axial cuts of L4-5, which is showing a large extruded and a caudal migrated disc causing significant compression of the left root. And these are the L5-S1 images, which is showing a small disc causing compression on the left-sided nerve roots. Discussion part. Should I wait or should I proceed?
I think you just go ahead, Dr. Faisal.
Yeah, okay, okay. What we did, surgery was planned as patient was having difficulty in walking and weakness in the left lower limb. Under general anesthesia in prone position, through a small 2.5 centimeter incision using tubular retractor from matrix, serial dilators passed in first at L4-5 level, and the laminotomy done, an extruded disc removed, and L5 root decompressed. Then by using the largest size tube in the retractor angled over L5-S1 called winding, and the foraminotomy done at that level, L5-S1 and the S1 root decompressed. These are the intraoperative images. This is the intraoperative image, which is showing this C-arm image, which is showing tube at the L4-5 level. And after decompression, after winding, this is tube at L5-S1 level. This is the incision and this is the extruded disc. Intraoperatively, we found a large disc extruded at L4-5 and very small disc prolapse at L5-S1. This is the post-op X-ray, which is showing this laminotomy at L4-5 and a small foraminotomy at L5-S1. Should I proceed or?
Go ahead, please.
Yeah. We got this inspiration from our secretary, Mishap, Dr. Arvind Kulkarni. In his book, Minimally Invasive Spine Surgery, he mentioned for two-level decompressions, a single-level incision may be adequate for the lower lumbar spine, whereas a separate incision may be used in the upper lumbar spine. Again, by Dr. Alexander Vaccaro in his book, MIS-SS, winding allows the surgeon to reach different areas of the spine. The tubular retractor can be angled or translated under the skin to reach a different area of spine, such as the contralateral side of the spine in lumbar canal stenosis or the adjacent level spine. Again, a tip by Alexander Vaccaro, winding of the tubular retractor is an important technique that allows access outside the surgical exposure. How it is done is the very important question, again by Alexander Vaccaro in MISS mentioned. This is performed by loosening the table-mounted retractor holder and placing the largest dilator through the tube to act as a handle for the manipulation of the tubular retractor. Few more references with the very latest one from the Journal of Spine Surgery in a Minimally Invasive Spine in June 2019. Moving the tubular retractor at various angles allows the surgeon to reach various areas of the spine, a process known as winding. Again, a very important tip, the tubular retractor can be winded, angled while applying steady downward pressure to avoid unwanted soft tissue encouragement on the operative corridor. A few pearls again from Dr. Arvind Kulkarni sir. He mentioned the incision should be 1 to 1.5 centimeters from the midline so as to allow winding for the bilateral decompression. There should be proper docking. Third, the most important thing, length of the final tube should be long enough to prevent muscle creeping into the surgical corridor. Few pitfalls while winding. If the incision is too small, there can be difficulty in winding. maceration of the wound edges, and the increased trauma to the paraspinal muscles. If the incision is too medial, wounding for the contralateral decompression becomes difficult and may fracture the base of the spinous process. If the incision is too lateral, a hypertrophied facet joint may get injured when docking and wounding. Last but very again important point by this Frank Phillips from MISS, minimize winding. He suggested minimize winding if possible, because this can lead to muscle creep, making visualization more difficult. Therefore, take the necessary time initially to dock in the best position using fluoroscopy. Thank you very much.